Good afternoon and welcome to the Institute for Health Policy Studies Grand Rounds presentation for today. Today I am very excited that we have Alyce Adams. Alyce is the inaugural Stanford Medicine Innovation Professor and a professor of epidemiology and population health, as well as a professor of medicine at Stanford. We are very happy to have her here. She leads a number of different projects and studies over the years on interdisciplinary research on racial disparities and socioeconomic issues and chronic disease treatment and outcomes. Prior to joining Stanford recently, she was the Associate Director for Healthcare Delivery and Policy at the Kaiser Division of Research. And I have long admired her work, so I'm very excited to learn from her today. So I'm going to hand it over to you, Alyce.
Appreciate that. I'm going to go ahead and share my screen. So first, before I talk, I just wanted to acknowledge the indigenous peoples of this land who are stewards of this land and our great appreciation for them and for their persistence and perseverance and their strong identity. So, as Joanne mentioned, I am now at Stanford, previously of Kaiser Permanente. I've been in the East Bay area for, about 12 and a half, 13 years now. And I have the privilege and honor of working at both the Stanford Cancer Institute as well as Stanford Medicine in the departments of epidemiology and population health, as well as health policy. A lot of the work that I'm going to talk about today has been work that I've conducted over the years, both at Kaiser Permanente and before that when I was at Harvard Medical School and Harvard Pilgrim Healthcare Institute, as well as my work with colleagues in the Healthcare Systems Research Network. So I just wanted to acknowledge the many people who've worked on these studies and helped us to really understand a bit about access and health equity. So in terms of sort of definitions, I just want to talk a little bit about health inequities, what we mean by that and how it relates to health policy. And in particular, American health policy is really characterized by incremental changes, as many of you know. We tend to make incremental changes in health policy over time to address specific needs. And policies that aimed at addressing disparities are often preceded by some shock to the system, some high profile event or alarm discovery that causes us to do something. Medicaid and Medicare are specific examples, also the Indian Health Service and other sort of significant policy changes over time. But what happens is because we tend to have an incremental sort of process for policy change, we end up kind of putting Band-Aids on the issues instead of addressing the real structural issues. And the picture on the right is, I really like this a lot. This is from the Department of Health in Vermont, and where they talked about in terms of inequities that we see, we know that there are structural and systemic factors that contribute to those inequities. Yet our policy is really are the crates that you see in the middle picture, right? We sort of put crates down. We try to give people a little bit more access so that we can have more equitable outcomes. But the reality is, until we address the foundations, until we address those structural and systemic factors that contribute to these disparities, we're going to continue to have some of the same issues and continue on this path towards incremental change and sort of fits and starts towards health equity. And just again, to want to reiterate, true reform is super rare in our country. And again, these sort of shocks to the system were generally what preceded, including the current issues that are related to both social injustices of the recent last year and a half, as well as the COVID pandemic. So what do I mean by structural and systemic factors? Well, this is a really nice, I think, figure that was done by Solar and colleagues that really sort of describes health inequities and where they come from. And so they really talk about these sort of structural determinants or things in that sort of that foundation I talked about, the soil that we walk on, those things that really sort of drive these inequities related to socioeconomic and political context, whether it's governance, macroeconomic policies, social and health policies, as well as cultural and societal values, and how those interact and cause differences in socioeconomic position, social class, gender, and racism, as well as differences in education and occupation and income. And those in turn interact with factors that are really more the intermediary determinants related to things like material circumstances, health and behavior, biological factors, psychosocial factors, and the healthcare system. All of these things interact and move together to create these social inequities. And really, I think this focus on right now, social determinants of health, is really focused on the structural determinants of health on the far left side. As you can see, health policy is squarely in that space. So I really study a lot around drug coverage policy and gaps in treatment access and use. The reasons are that most people use medications. Most older adults have more than one chronic condition that are dependent on medications, both for survival, but also for prevention and treatment, and really sort of quality of life improvement, and particularly in areas like cancer and diabetes and hypertension and depression. And yet, prescriptions are often going to go unfilled. And it's estimated, this has sort of been thrown around for a long time, this 50% of non-adherence to medications is an ongoing issue. And in particular, this non-adherence has been estimated to cost particularly $100 to $300 billion per year, just in terms of chronic disease treatment costs. Yet disparities in adherence emerge early and are persistent across different conditions. We've identified disparities by race, ethnicity, and socioeconomic status across many different chronic conditions in terms of adherence to these medications that are considered often life-saving, if not clinically essential. And they often appear early. And again, in the course of disease, and on the right-hand side is some work that Dr. Trinasti did with us on her K Award, where she was looking at differences in the adoption of sulfonylurea treatment as well as metformin therapy among people with diabetes, and showing differences very early on in an integrated system where everyone has equal access to healthcare. We saw these differences among Blacks and Whites, and we've certainly seen that again and again. And the adherence literature is primarily focused on individual behavior change. So what interventions can we do to get people to adhere to their medications? Yet what's interesting is policy level interventions have a greater potential, not only for immediate and broad sweeping impact on health behavior as well as prescribing behavior, but they have the potential to be longer lasting than individually focused interventions. And so as an example, when we look at something like Medicaid, for example, the role of Medicaid and Medicare in prescription drugs, 40% of prescription drugs are covered by Medicaid and Medicare alone, right? So that's not even counting as something like 14% that's covered by individuals and then private insurers. So Medicaid and Medicare have a lot of skin in the game when it comes to prescription drug costs. When we look actually at policies and who's living where, we see a lot of variance in terms of how these policies are applied and the generosity of these policies related to prescription drugs in particular. And this is just an example actually of Medicaid generally speaking and Medicaid expansion. So expanding who's actually eligible for Medicaid. On the left-hand side, you see people living in poverty. The really darker states are where you have more people living in poverty. Many of those same states are also orange on the right-hand side, which are states that have not adopted expansions for Medicaid coverage, as well as those who in the lighter blue who have adopted it but not implemented it. So often we see this mismatch, right, where we see a lot of need and it varies across the different states. But then when we look at policies in those states, it's often just the opposite, where the states that have more people who tend to be impoverished and may have more need for coverage, having less coverage through Medicaid. So a lot of our work has been focused on really trying to understand these Medicaid level policies and how they impact different populations, particularly those who are low income and racial and ethnic minorities. And so we did a series of studies where I was a project director of looking at prior authorization policies among dual eligibles. Dual eligibles are those who are eligible for both Medicaid and Medicare. They tend to be very low income and have very high rates of disability, permanent disability. So it's a very vulnerable patient population. We really wanted to understand how does something like prior authorization, which is really aimed at driving people towards lower cost treatments and away from higher cost treatments, how that might affect these populations. And basically this is what we found. So we found definite shifts toward preferred drug classes. So remember before I said the policies have the potential to have big impacts very quickly. And we certainly saw that. So here this is comparing Michigan and Indiana who have adopted it but not implemented it. So often we see this mismatch, right, where we see a lot of need and it varies across the different states. But then when we look at policies in those states, it's often just the opposite, where the states that have more people who tend to be impoverished and may have more need for coverage, having less coverage through Medicaid. So a lot of our work has been focused on really trying to understand these Medicaid level policies and how they impact different populations, particularly those who are low income and racial and ethnic minorities. And so we did a series of studies where I was a project director of looking at prior authorization policies among dual eligibles. Dual eligibles are those who are eligible for both Medicaid and Medicare. They tend to be very low income and have very high rates of disability, permanent disability. So it's a very vulnerable patient population. We really wanted to understand how does something like prior authorization, which is really aimed at driving people towards lower cost treatments and away from higher cost treatments, how that might affect these populations. And basically, this is what we found. So we found definite shifts toward preferred drug classes. So remember before I said the policies have the potential to have big impacts very quickly. And we certainly saw that. So here, this is comparing Michigan and Indiana, who have adopted it but not implemented it. So often we see this mismatch, right? Where we see a lot of need and it varies across the different states. But then when we look at policies in those states, it's often just the opposite, where the states that have more people who tend to be impoverished and may have more need for coverage, having less coverage through Medicaid. So a lot of our work has been focused on really trying to understand these Medicaid level policies and how they impact different populations, particularly those who are low income and racial and ethnic minorities. And so we did a series of studies where I was a project director of looking at prior authorization policies among dual eligibles. Dual eligibles are those who are eligible for both Medicaid and Medicare. They tend to be very low income and have very high rates of disability, permanent disability. So it's a very vulnerable patient population. We really wanted to understand how does something like prior authorization, which is really aimed at driving people towards lower cost treatments and away from higher cost treatments, how that might affect these populations. And basically, this is what we found. So we found definite shifts toward preferred drug classes. So remember before I said the policies have the potential to have big impacts very quickly. And we certainly saw that. So here, this is comparing Michigan and Indiana, who have adopted it but not implemented it. So often we see this mismatch, right? Where we see a lot of needs, we actually saw a decrease in the study state with respect to use of initiating any bipolar medication, which again, in a case for bipolar, where you often see dramatic impacts of non-adherence related to hospitalization and other adverse consequences of non-adherence in bipolar disease, you really don't want to see a lot of people declining or not being prescribed these medications as a result of this kind of a policy. Again, even though that was not the intent of the policy, that's what happened. So we also looked at transitioning from states with super restrictive drug caps. So basically, they limited the number of prescriptions that you could actually be reimbursed per month under the Medicaid program, who were switched when Part D came online, Medicare Part D's drug coverage program, because all duals were automatically switched from Medicaid to Medicare Part D. So we took advantage of that natural experience, if you will, where we had people who were already living in these states with really restrictive policies to say, well, what was the effect of that, particularly on disparities in terms by race, in terms of who's using what medications, because we wanted to know, could shifting everyone from more restricted to less restrictive prescription drug programs, in particular Part D does not allow for drug caps, would that actually increase utilization? And the answer is it depends. So we looked at the use of lipid-lowering medications among people with diabetes. Again, we looked at a number of different conditions and treatments. But in this case, the top row, what you see are for non-elderly patients, a distinct increase in the use of lipid-lowering medications among the dually eligible population who are eligible for lipid-lowering drugs relative to to states where they did not have drug caps pre-policy. So everyone got switched to Part D. Some were coming from more restrictive and then less restrictive states. In the bottom half, you see this impact among elderly patients. And it was very, very similar, where in states where they were coming from very restrictive policies, when they moved to Part D, we saw an increase in the utilization of those medications among people with diabetes. We then looked at the Blackwhite gap ran across a number of different conditions, in this case among cancer survivors, and actually saw what we thought we might see, which is that the policy had a dramatic effect on gaps in use prior to the policy. Prior to the policy is represented by the dashed line. So what we see is an increase towards increasing gaps in the use of these medications, whether it be antidepressants, antihypertensives, or lipid-lowering medications, when we compared white patients to Black or African-American patients in the sample. And what we found is a nationally representative sample of Medicare Part D enrollees. And what we found was that that increasing trend towards greater disparity in the use of medications was actually dampened by the impact of Part D among cancer survivors. However, that wasn't the case among people with diabetes. When we looked at people with diabetes, this is a case of antidepressant use, what we actually saw was either a persistence of pre-existing gaps or disparities in the use of these medications, or in this case with antidepressants, an actual increase in the gap in the use. And the above graph really just sort of shows the lighter line is the whites, and then blacks are the darker line, and it basically shows the gaps between them. The starred line is the difference, right? And so it shows like a steady sort of 5% gap between whites and blacks, the proportion of users of antidepressant therapy that actually started to increase after the policy, mostly related to increasing sort of response among white dual enrollees to the policy change. Similarly, if you look at the bottom graph, it really sort of just shows a similar effect where we see sort of this jump up in sort of the standard monthly doses in terms of the gap between the two groups, primarily because whites were more responsive to the policy than blacks with respect to the utilization of antidepressants. So, moreover, prior authorization was highly effective, if a blunt instrument for reducing prescription drug costs. However, in shifting towards prescribing more preferred drugs over non-preferred drugs, there was also this dampening of new users overall, as well as disruptions among those who were already established on therapy. So while there were exclusions in the policy to protect vulnerable populations from that kind of disruption, it was in super fine print, literally, in the policy. And most people didn't read that part of the policy. They just sort of reacted to the overall prior authorization and the hassle that was created by the prior authorization. So again, it sort of shows that sort of prior authorization was very, very effective in shifting, but it was less sort of a refined tool for really addressing and avoiding sort of these unintended consequences for particularly vulnerable patient populations. We also saw that removing drug caps would improve access overall across a number of different conditions and treatments, but it wasn't enough to address persistent disparities in treatment, particularly among diabetes patients. And in at least one case, it actually exacerbated those disparities in treatment. So the case is sort of the question was sort of why? Why is this happening? Why isn't it when we open the doors more, where we increase access, that we're not actually seeing the reverse? So in prior authorization, we saw these unintended effects among vulnerable populations. So you would think increasing access would make things better, and it didn't quite. It did in some cases, but not in others. And so that really sort of left us scratching our heads. But I think it is highly consistent with what we've seen in other places. And in particular, Hart has this inverse care law that he talks about. Other people talk about inverse equity hypothesis. But basically, it's that when we open the doors and we try to expand access, whether it's coverage or an innovation of some sort, often what we see is those who are already connected to the system often take advantage of those things first. And so initially, we often see this widening of gaps, particularly between socioeconomic status, between groups, before we see everyone sort of get full benefit from the expansion in coverage. Right. And so it's that widening that we want to be able to do something about. And I think that's one of the areas where I think health equity has to go as we start thinking about how do we improve access to care? How do we address some of these continued disparities in treatment outcomes? We need to address that widening gap, the potential to make disparities worse first before making them better. So how do we do that? So I think there's a number of things that we can think about, and I'm looking forward to talking to all of you about these issues. But one is thinking about stakeholder engagement. In particular, often we design policies with certainly using the literature that we have available, and we try to sort of focus on specific goals in mind. Yet, we very rarely do we invite patients and communities to the table when we're talking about how do we develop interventions that really work. And so I think stakeholder engagement is key because we can understand the context of how care is delivered. So an example in one of the studies I just showed you from Maine, when we looked at the bipolar treatment, what we found is that when we redid the analysis among groups who actually had a regular provider from FQHC versus those who didn't, those who had FQHC providers as a regular source of care seemed to be better off. They weren't as affected by the policy compared to those who did not have a regular source of care through FQHC, excuse me. So that suggests that there are nuances and context at the local level that we may be able to leverage in order to avoid sort of that widening of the gap that we see when we actually try to expand coverage and or to dampen the potential negative effects of policies, especially those that are involving cost containment. I think also this move to integrate social determinants of health data is huge because we can understand and anticipate the equity effects of policy options. I showed you before this sort of geographic differences. When you get down to a local level, you see it even more so, right? We all know we see these differences. Where you live matters in terms of how you interact with the healthcare system, how you respond to different things, and what your outcomes are for treatment. And so being able to integrate information about the social determinants of health, food insecurity, in other words, competing needs for resources other than treatment, other factors, how close you are to public transportation, how close public transportation is to where you get your health care, all of those things in the end matter. And so understanding those at a population level can better help us to understand how individuals respond to these policy changes. I think also designing concurrent community level interventions that leverage community assets is another way that we might want to think about addressing these issues, particularly with health policies in terms of the unintended consequences. And certainly health reform in Massachusetts, they attempted to do some of this by anticipating ahead of time that there might be issues in rolling out healthcare reform across different areas. And so they tried to work with community partners to make that more effective. And certainly I think integrating that increasingly in the work that we do to make sure that those community level interventions, not only can we analyze them simultaneously with the policy level interventions, but also that designing community level interventions that can co-occur with those policies has the potential to then address those contextual factors that the policies are simply too blunt to be able to get to. And then finally, I would say rapid policy analysis and dissemination are critical. The studies that I just showed you, we did over a series of years. In most cases, the policies that we were trying to study had been implemented for years after we actually published the results. And that's very dissatisfying, right? As a health policy researcher, you want your research to matter. And so we've been working on ways of doing sort of more rapid policy evaluation in a way that will help us to get ahead of the problem. But also I'm interested in issues related to, can we sort of anticipate the reaction to these problems? So we're actually looking at things like, can we use causal inference methodology or simulation in order to try to identify ahead of time what's the likely impact on different subgroups of different choices, and how might that then influence how we design the policy in the first place? So with that, I'm going to stop and open it up to questions. Thank you so much for your attention. And again, I just want to acknowledge my colleagues who've been a part of this work and their amazing efforts to help us to get those studies done and to really see sort of the impact of those different policies on vulnerable populations. Thank you.
Thanks so much, Alyce. That I feel like each of the components that you discussed, you could have spent more than an hour on. So everybody who's attending, you can please put in your questions in the Q&A box in the Zoom session. And Justin White actually had a question from early on when you were talking about the Pennsylvania research. So he asked, do you have ideas of the mechanism that reduced the new prescriptions for depression in Pennsylvania?
Absolutely. So yeah, there was actually Michigan was one, and the other was Maine. And what we found was we actually looked at the policies themselves, and they were thick. There was a lot of text, but ultimately what happened was, in order for a physician to be able to prescribe a particular medication, they knew that for some medications, they were going to have to go through essentially a prior authorization office where they would have to call and get special permission. And so while there was a list of drugs that applied to, and a list of drugs that did not apply to, as well as a list of people it did not apply to, and fine print at the bottom, for a lot of providers, that hassle factor, which we sort of called it, probably prevented them from writing the script in the first place. Right. So rather than try to go through the trouble of figuring out which drug can I prescribe or not prescribe, or is this patient eligible or not, it was easier to not prescribe at all. So we suspect it was really on the prescriber end. And what was nice about that study is we were actually able to get a couple of people from the Medicaid offices to come and be on the study and be advisors on the study. So they were also able to talk to us about, there was this effect, this hassle factor for the clinicians that really made it frustrating for them. And in the case of Michigan, at least, I believe the policy was then rescinded in part because they couldn't get the nuance that they wanted. You know, they were really looking for something that would be sort of sleek and nuanced that would allow them to shunt people over to particular types of medications. But it just was really hard to do that through this policy because sort of the nuance was lost. And so it was not having the effect that they had hoped for.